Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of the September 11th issue of JACC. Theoretically, patients who've received aortic valve bioprosthetic devices are susceptible to thromboembolic events or even death shortly following surgery. But a major unresolved question has been whether or not those patients with bioprosthetic aortic valves would benefit by being anticoagulated in the early postoperative period. To answer that question, in our latest issue of JACC, 25,000 patients existing in the Society of Thoracic Surgery database were analyzed. The endpoints that were looked at were the 3-month incidence of death or embolization. Now, they looked at 3 separate treatment strategies: aspirin alone, warfarin alone, or combined aspirin and warfarin. An important finding was that thromboembolic events were very, very low regardless of therapy. In fact, they were less than 3%. Aspirin therapy and warfarin therapy were essentially equivalent. Now, if you use the combination of the drugs, you got less events, but you got more bleeding. So as we've seen over and over again with antithrombotic therapy, the higher you go in the antithrombotic effect, the more apt you are to have bleeding, and so you trade a lower event rate in exchange for more bleeding events. One of the really interesting issues regarding the use of biomarkers in cardiology is whether they can be of value in identifying patients who have silent cardiac damage in a primary prevention disease population. So can we use biomarkers to screen the population to identify those patients who may in fact have underlying cardiac disease? And so a study was conducted that's in our most recent issue of JACC that specifically studied BNP and troponin and whether or not they were capable of identifying silent cardiac target organ disease in patients who have no clinical evidence of underlying disease. They looked for 5 specific targets: ischemia, left ventricular hypertrophy, systolic dysfunction, diastolic dysfunction, and left atrial enlargement. So in examining 300 primary prevention patients, they found target organ damage in 34%, a higher population than I ever would have guessed. Now, in doing area under the curve receiver operating characteristics analysis, the AUC for BNP was 0.78, for troponin was 0.70, and if you combine them, the area under the curve was 0.81. Not too shabby. So these investigators concluded that combined BNP and troponin may be useful for screening primary prevention populations and determining whether or not to go on to a more advanced test, for instance, an echocardiogram or a stress echo or nuclear study. A common problem encountered after surgery for tetralogy of Fallot or other congenital abnormalities is significant pulmonic regurgitation. And oftentimes we're confronted with these patients as they reach adolescence and adulthood, and the question is, when should pulmonary valve replacement be considered for these patients with pulmonary regurgitation? And so in a very nice paper we've got in press in JACC, the authors retrospectively analyzed 170 chronic pulmonic regurg patients, and they studied them using magnetic resonance imaging, so very precise measurements of right ventricular size and function. They determined, looking at these patients retrospectively, that the cutoff value to achieve an optimal result from surgery, the optimal result being defined as normalization of RV volumes and function, was 80 milliliters per meter square value for right ventricular and systolic volume index. Thus, based on these studies, and this is the largest study available, Pulmonic valve replacement should be strongly considered before the right ventricular end systolic volume index reaches 80 mLs per meter square in patients with chronic pulmonic regurgitation. A bit of information that I personally will find very useful in dealing with these patients. So these data, along with many other in the September 11th issue of JACC, really provide some important information for clinical cardiologists. For Inside JACC, I'm Tony DeMaria.